Always when the class 2 and the class 3, as you are going to plan for surgery, so you want to procline lower incisors, high torque, amazing. For the upper incisors, do you agree with him? For the upper incisors, he said low torque. Yes. So yes, we'll pick low torque. At that time, I was testing the Big Brother rule. So I think I picked low torque for both the central and lateral. We'll see the torque, but this is hair profile with centric occlusion. So this profile is not treated without surgery. But if I ask hair to bite edge to edge, this is hair profile. Even the nose is different. So by this profile, yes, I can try without surgery. But with this profile, no way. She will need surgery. So I took that as my reference. And again, yes, I put my brackets as 6.5, high torque in the lowers, low torque in the uppers. For the canines, as we have said, in most of the cases, you'll put high torque. I added bite razors on the two centrals. So this is hair bite from day one. So she entered the practice like this, and she left the practice like this. She survived, don't worry. Yeah. Of course, I extracted lower wisdom teeth, but I kept the upper wisdom teeth because I planned to protract 6, 7, and 8 at the site of upper 6. Again, still she has the bite razor. I had the space medial to lower canines. So now the lower arch should have asymmetrical retraction to the right because the midline is shifted to the left. So always with the class 3 cases, prepare yourself for asymmetrical mechanics. This is the last photo that I did to her, but I will share with you the lateral SAF. She is still under the treatment. Again, she will leave the practice like this. So she will lose some weight. Yeah. Yeah. But remember this extrusion. Now we have a space mesial to lower canine because of our class 3 elastics. These are crimpable hooks. I'm doing retraction to the right more than the left. And still, I'm using my bite razor. Because she lost the 6, I put mini screw between 5 and 7 to do two things. To have intrusion for my 7 and to have some sort of mesialization. Because while you are using class 3 elastics, what will happen for this 7? It will extrude, it will come down. Okay? This is my mini screw. So I protracted the 7 and the 8, and now my lower arch is leveled. So we are in the finishing stage. Now she is in class 1, by the way. Again, on the left side, we have bigger space. That's why we are doing intrusion with mesialization. This space created because we extracted the wisdom tooth and we are using class 3 elastics. We call this anterior triangle class 3. While I'm keeping my mandible in class 1, I want to increase the vertical correction. I want to show more of hair incisors. So we call this anterior triangle class 3. I boarded my 8. This is the site of the extraction. She has severe gag reflex. So it was almost impossible to take photos. Because I did IBR, if I go back, you have contact, but no connectors. Here you'll see that, no, we are improving the contact. This is 7, 8, 7 and 8. This is my bite tracer, and we did a fatal mistake here. What was the mistake? The color should be pink, isn't? Yeah. That's why I changed the color later on to pink. Reverse overjet, I changed it to pink. And this is my last, almost we are in class 1, but because I put the ruler, she couldn't have this maximum intercuspation, but this one is in class 1. It was in class 3. And again, the canine is part of your buccal occlusion, not part of the anterior segment, okay? This is her lateral shaft before, and this is during. Remember, these are the 8s, still unerupted. I have them now in the arch. The lower incisors, they were extruded, now they are intruded. The proclination of upper incisors, even I'm using class 3 elastics, because I'm doing low torque with IBR, I have some sort of correction. Do you think still she needs surgery? No. Still, I'm working on to have the maxilla in more forward position by doing IBR with low torque on the uppers. I need retroclination, and I want my maxilla to move forward. But don't forget, she had extracted upper 6s. So this was challenging, because if you extract a tooth, you are not removing only the tooth, even you are removing the bone at that side, okay? So this is her profile at the start, and this is still during the treatment. You can see the amount of support below the eye in comparison before. Even the lower facial third was reduced, now was restored. Easily you can see the support here and here. Even the sclera below the eye, you know? So what we are doing is skeletal change. It's not only dental. And easily you can see the support below the nose. And because we put the brackets as 6.5, you will see the change. So the incisal edge, show is better, but we need more. Okay, we need more. But this is a challenge with the class 3 cases. But you can see that she has reverse smile arc. Now she has positive smile arc. All of that is introduction about the class 3. So we want anterior posterior correction in class 3. How we can do that? This is the protocol. We need anterior posterior correction, and it depends on combination between palatal class 3, it's not a class 3, because always the maxilla is constricted. So I want to expand the maxilla and to correct the anterior posterior problem. So if you apply palatal, you are doing both. You are expanding the maxilla to correct the crossbite, and you are doing anterior posterior correction. Why I didn't do that in Shahd case? Because I don't have first molars. So it was impossible to reach the palatal side of upper 7s. That's why I put class 3. But you will see now more of my cases. Most of them, I have palatal class 3. But in Shahd case, she had extracted upper 6s. It was no way to reach the palatal side of upper 7. So I'm using palatal class 3 elastics in combination with anterior bite razor on lower two centers. This will give you three effects. Expansion of the upper arch. This will correct the cross bite in transverse dimension. So no need to put cross elastics. The palatal class 3 elastics will do this. Also, face mask effect on the upper arch, which is the mid-face oriented treatment. You remember, I will put low torque on the upper incisors, and because of class 3 mechanics, the whole maxilla will move forward. So this will support the mid-face. Also, by applying class 3 elastics, this will do distalization on the lower arch at the site of extracted lower eighths. And this will give you space mesial to lower canines. You remember Shahad case? There was a space mesial to lower canines because of distalization. Then later on, to correct your lower midline, you will do asymmetrical retraction, because always in class 3 cases, use asymmetrical mechanics. Always the midline is shifted. So this is, let's say, the guidelines, the principle, the concept of class 3. Let's say tomorrow you will have a class 3 case, okay? All of you, take care. Try to avoid hand to chin support habit. This will affect the TMJ and it will affect the symmetry of the face, okay? So in details, if I'm going to do a class 3 correction, I'll do the following. It's the opposite of class 2. So in class 2, you have to extract upper eighths. In class 3, you need to extract lower eighths. But again, it depends on the age. If you have very young patient, you will not do that. But if you have 16 and above, it's better to extract lower eighths. No need to use cross elastics because you are using palatal class 3 elastics. This will correct the cross bite. Bless you. Again, your first goal to establish class 1 buccal occlusion in the first 6 months of treatment. Your palatal class 3 elastics from palatal button of upper sixes to lower canines will create space mesial to lower canines. For lower anterior segment, forget about them. Okay, keep them as one island, one group. I mean the lower anterior segment. Don't correct the midline till you have buccal class 1. So once you reach salicyle wears, you can start the retraction of lower anterior segment, and in most of the cases, it will be asymmetrical. Why not to have some cases? Your turn. Hey. Your turn. Okay. Agree with you. The incisor show is okay with him. But what will happen with the class 3 mechanics with time? You will have some sort of rotation of the occlusal plane because of class 3 elastics. So always with the class 3 cases, even if you are happy with the incisor show, it's better to put your brackets 6.5 or even 7 millimeters, okay? So I will answer that question instead of you. We'll put the brackets to create a smile in class 3 cases. In most of your class 3 cases, you need to show more of the upper incisors. That's why even it's not 6.5, it's 7 millimeter, okay? That's why at the end of the treatment, you'll see that the incisors show reduced. So if I can go back to treat him again and put my brackets as 7, not 6.5. And he has concave profile, and the chin-throat distance is normal. By the way, you need to think about this. this profile needs surgery, especially if you see the lateral sap. Okay? He couldn't bring edge-to-edge bite. And the upper incisors, they are proclined. Lower incisors, they are retroclined. And even with that, he couldn't bring edge-to-edge bite. So for me, even he is a surgical case. But if you send him to your colleague to do surgery, he will tell you, I need to have 10 millimeters of anterior posterior correction, and to have a stable result, my maximum in the maxilla will be 6 millimeters. So I need to do mandibular surgery also, in addition to the maxilla. So they will advance the maxilla and they will retract the mandible. What will happen to this male profile if they will do mandibular surgery? They will kill his face. Because part of the beauty for males is to have this distance. If they cut the mandible and they do sit back, they will give him some sort of bird beak profile. Okay? That's why it's better to avoid mandibular surgeries in males in class 3. It's better to avoid mandibular surgeries in class 2 females. In males, it's better to give them tendency to class 3. In females, it's better to give them tendency to class 2. So class 2 surgeries avoided in females, class 3 surgeries avoided in males. It's part of the beauty to have a class 2 in females, or tendency to class 2, or tendency to class 3 in males. So it's contraindicated to do surgery for him, by the way. The other thing, as I have said, always with the class 3, we will see that the mandible is shifted to the right or to the left. Once you will see that the mandible is shifted, you will think, oh, the only way is to do that with surgery. But as I have said, mandible is a follower. Once you correct the maxilla, you will have some sort of spontaneous correction of the mandible. That's why I didn't plan any mandibular surgery for him, even for the chin position. Even you see that the chin is deviated to the left. No way to have true correction in this case without surgery. And his mandible is shifted to the left with complete crossbite. Reverse overjet. And see this 7? No occlusion. Okay? And upper arch, lower arch, they are aligned. So you don't have a crowding or spacing for camouflage. So if I'm going to treat him, it should be a true treatment. Okay? And as I have said, here you have full unit class 3, here no, you have half unit almost class 3. So you will not have true class 3 in both sides. That's why his mandible is shifted to the left. So what you are going to do for the wisdom teeth? Yeah, you will extract wisdom teeth. And the wisdom teeth, all or none. So if you are going to extract lower one, extract the upper one, okay? And what you are going to pick torque for the lower arch. What torque that you are going to pick? High torque, especially the canines, okay? And what you are going to pick as torque for the upper incisors? Low torque, yes. Except for the sentinel, they should be standard. But I did a mistake. I picked low torque for both of them. So yes, we extracted upper and lower wisdom teeth. High torque in the lowers, low torques in the uppers. This is almost 6.5, but next time I'll put it 7, by the way, for him. It's better to have more gingival position for class 3 cases, especially class 3 cases. And for the bite razor, for you, where to put the bite razor? Yeah, lower 2 centrals. Yeah, lower 2 centrals. In the class 3 cases, most of the cases, lower 2 centrals. So this is the day of bonding. And these are the palatal class 3 elastics. See them? Palatal class 3 elastics. Why? I want to expand my maxilla in addition to anterior posterior correction. And instead of putting 4 elastics, 2 elastics, they are enough. Am I going to correct the midline now? No, it's early. Because he has well-aligned arches, I could put 18 upper and lower from day 1. So the first wire was till the 7th. And this is my palatal class 3 elastics. These are the palatal buttons for him. Again, fatal mistake. Yeah, should be blue, isn't it? Yeah. But sometimes you don't have that color, okay? While I'm applying class 3 elastics to the canine, I didn't get space mesial to lower canines. Why? Because see this lingual tilting? And you remember, if you want to create anchorage in orthodontics, one of the techniques is to push the roots against the cortical plate. So already the roots, they are touching the cortical plates at the canine. So no way to have anterior posterior correction. That's why in his case, I shifted my elastics to the lower first premolar. So I put my elastics instead of the canine to lower first premolars. No space, no space. So I want to distalize this segment first, then the canine. That's why I left part of the wire for the sliding. Now I had space mesial to lower 4s. That's why I put my elastic from 6 to the canine. But if you see, I put buccal on the right, palatal on the left. Why? Because I want to have my mandible to the right, the whole mandible. If you see the elastics, they are like this, not like this. I mean the direction of the force is to the right. So at the end, the mandible should move a little bit to the right. So I put buccal on the right, palatal on the left. It was a trial for me. Why not to try this? And it was successful, by the way. It brings the mandible more to the right. This is the space that I talked about, mesial to the lower 4s. Now it's time to distalize the canine. I'm using palatal on the left side to close that space. This is the space that we created, mesial to lower 4s, and it's time for the canine now. That's why I use that palatal button on the left side. Because of that, yes, I could have my mandible to the right. I need more of class 3 elastics on the right, less on the left. Because here we had now class 2 instead of class 3. Overcorrected. That's why always remember, in class 3 cases, you need asymmetrical mechanics. Now we are in the finishing. I did IBR upper and lower. Later on, I removed these brackets. I put standard torque and low torque. I put them at 7. So most of your mandibular deviation, they are not skeletal. They are functional. This is overcorrected. You remember the 7? It was here. So from reverse overjet, this is the day of bonding. He couldn't bring edge-to-edge bite. Now he is in class 1. We start with the class 3. So from class 3, this is the canine, the lower 4 and 5. Now upper canine, lower 4, ideal class 1. Again, all of that, not to do dental change, is to do skeletal one. So his lateral staff before, during, after. Before, after. So the change was real one. Especially, remember, there was 8 here. It was extracted. And I feel that I will need mandibular surgery for him, for the deviation. Now, almost he has symmetrical face. So again, correct the maxilla and the mandible will be a follower. You can see the amount of mid-face support. But for the smile, I was not happy. Why? Because he has now flat smile arc. Why he has flat smile arc? Because of prolonged class 3. So if I'm going to treat him again, I have a different protocol. I'm not sure if it is okay to share with you severe class 3 cases. I'm afraid that you will be confused. So, you want me to go more towards severe class 3 cases and to show you how to prevent this? Okay. For the profile, this is his profile before, and you will please follow the mid face. If they do surgery for the mandible, this chin will be here. So no distance between the chin and the throat. And so by this, they will kill the profile of a male guy. Already the occlusal plane is normal. It's not with downward rotation. So with the class 3, it will become like this. And especially he has severe class 3. And he is 47 years old. I told him, you need surgery, but we'll try with you. Again, complete crossbite. 7s, they are out of occlusion. He has a lot of crowns, constricted maxilla. Already he extracted the 8s. I picked high torque for the lowers, low torque for the uppers. This should be standard torque. I put the brackets as 6.5. I started with palatal class 3 elastics. we created space mesial to lower canines. I did asymmetrical retraction to the right. So we are correcting the lower midline. For the overjet, full unity class 3. Now, almost he is in class 1, we created space mesial to lower canines. Now he is in class 1 canine, okay? I corrected his occlusion, okay? But by the way, don't start with this tomorrow or after tomorrow, okay? Try with the class 1 with the crowding, class 2, mild class 3, okay? So then don't go to severe cases from the start. You need to test your tools, mechanics, protocols, torque, everything, okay? And I told him, we will stay together 1 year, but if we failed, we'll go for surgery. So he accepted. So almost I corrected his class 3, but if you look for the occlusal plane, it's rotated upward. You will not like his smile now. So bad, isn't? You don't like the smile. Why? Because of class 3 mechanics. So what to do? I didn't read this in box, okay? I want to rotate the occlusal plane while I'm in a class 1. So what I did, I added 2 screws, mesial to lower canines. And I kept using anterior triangle class 3 elastics. But they were not enough. So I decided to go for something else. So what I did 2 screws in the upper arch. You'll see them now from the buccal view. Then I added another 2 screws distal to 4s. So this is what we did. I did 1 screw between 5 and 6. I did 1 screw between 4 and 5. I'm applying this force from 7 and applying this force from K9. So what will happen for the occlusal plane? You will have some sort of clockwise rotation or counterclockwise rotation. Yeah, you will have clockwise rotation. So this force will push my maxilla in more forward position, and this force will push my mandible in posterior position. This force will do intrusion, this force will do intrusion. So the net result will be rotation of the occlusal plane. I stopped using elastics, no elastics, and I could achieve gradual correction, you know? So if you have severe class 3 elastics, you need to put your brackets at 7.5, and you need 1, 2, 3, 4 screws to correct your occlusal plane. This is if you have a very severe class 3. I'm afraid that you will forget everything that I said before and you will stick to this idea. You will not have this case every day, okay? Again, 2 screws, but this one was failed between 5 and 6. That's why the only solution is to have it in a new place between 4 and 5. But the same direction of the force. He's doing great, and I'm sure I found a solution for his case. And this is what I need from you, okay? To take records and to build your own recipe. But without taking records, you will not be able to do that. So keep taking photos, or what you have seen on the screen is my work. You can do that. You can do editing, you can do lecturing, just take records. So one of the things you need to set a studio, special studio for extraoral photos with white background, and you need to pick your intraoral camera. And of course, it will be learning curve. If I will share with you my old photos, you will laugh. They were so bad. But with time, everything is improving. This is the first wire, but I extended to the 7 because I want to get my 6 out of the crossbite. And I told him, he is 47, okay, and he is managing one of the centers, eye centers in Jordan. So, and he is engineer. So he will understand me. I told him, look, I should keep my wire till the first molar, but I will extend it to the second molar. If the wire come out, you can cut it. That's why I made that risk to correct the crossbite. I'm using these palatal buttons for palatal class 3 elastics. So the upper arch now almost done. This is the upper arch with elastics with the mini screws. For the lower arch, this is my bite razor. I added another composite build-up. This is the space after desalizing this part. I did rebonding for some brackets. This 4 and this 4. I'm doing asymmetrical retraction to the right. So this is asymmetric retraction to the right to correct the lower midline. He couldn't bring edge-to-edge bite, and it's a true class 3 on the right side. This is my space mesial to lower canine. We established class 1, but because I added mini screws and I stopped elastics, we lost some of the correction. This is X-ray after adding these 2 mini screws in the front region, but I'm going to take another lateral shaft after adding the buccal mini screws, upper and lower. Of course, we are improving his incisor show. He's doing great. If we are going to meet later on, you can see his smiling photos. He's still under treatment. But for the profile, even without his beard, okay, he's improving, even after shaving the hair, okay? This will give you improvement better than without hair. So you can see the mid-face support. You can see the mid-face support. So my advice, in severe class 3 cases, I will put my brackets on upper incisors as high as possible, 7 millimeters, to counteract the upward rotation of the occlusal plane. At that time, I said I will, but already I did. I will use TADs on both arches, between 5 and 6 in the upper arch and 4 and 5 in the lower arch, to prevent rotation of the occlusal plane. That's why if you have downward rotation of the occlusal plane is favorable in severe class 3 cases. He has normal occlusal plane. That's why you see the tilting. If he had this is much better for you. Okay? But his case, of course, will give you an idea that you need to explore your limits. You can try with some severe cases. I used to tell my participants, really, today and tomorrow it's heavy dose. So don't expect to have everything once. So if we have 100% information, and at the end of tomorrow we will have only 20% of what I have said, it's enough, okay? Of course, you need to attend more courses, okay? So each time you will pick something. The alternative for class 3 elastics is to wear chain cup, which is not sense, okay? And for the IBR, yeah, IBR is a substitution for extraction. If you have flared lower incisors in a class 2, the only way to retrocline them, even for surgery, is to extract lower fours. So tell your patient or the parents, you need IBR or extraction. Okay, I'm okay with both of them. No, doctor, go for IBR, we like it and it's amazing, okay? So yeah, give the options for your patient, extraction or IBR, because this is the only substitution for IBR. If you want to retrocline lower incisors, you need space. What are other means? Already you did arch development, okay? You have only 2 options, IBR or extraction. And it depends on your way. When you say, I'm going to bring this abrasive strip and put it between your teeth with this handpiece and it will do bzzz, okay, he will be afraid and he will refuse that procedure. But if you show him a case, beautiful case, and tell him, this beautiful result was done because I did IBR. Doctor, please put IBR on me. Okay, I like the result, okay? And try to make it with a professional kit. Try to use the complete set of strips from 15 micron till 90 micron. You need 5 strips. And I have 2 kits at my practice. I mean, handpiece with refill. For the refills, I think we have 3 or 4 kits for strips because I need them. I need them, and once it's okay for the first time of the IBR, the patient will accept it every time. If they refuse, tell them the result will not be accepted for me and for you, and it's okay. You need to approve that. And I heard from Dr. Fung that there is another third question. So it was class 3, IBR, and Bigger Brother rule, yeah. Yeah, my rule, yeah. You can say Badr Burgan rule, yeah. It's my guideline. And again, I told you this morning, I want to share with you my recipe. You are free to take it or leave it. You can put all the brackets on the upper incisors without this Bigger Brother rule. But I'm sure at the end, no. You will feel it's better to try mine. But if you are using Insignia, no need for that. As I have said, when we say bimaxillary protrusion, we should differentiate between mild and severe. And when we say severe, my classification is the upper is a class 2, the lower is a class 3. So we'll apply class 2 mechanics or class 2 protocol and with the class 3 protocol together in severe one. But for the mild one, we have mild and we have severe. For the mild one, it's easy. We'll pick low torque in most of the cases, but remember Big Brother rule. You need to eliminate any rotation to create any crossbite and to finish your pano-revo. Then, while you are having upper and lower 18 by 25, you need to do gradual IBR using the strips. This gradual IPR with low torque will give you gradual torque expression of larger wires to close the spaces. No need for power chains. And as I have said, tell patient or parents that you will do this every visit and give them the choice, IPR or extraction. Yeah. And of course, we need nasal breathing, lip seal exercise using upper lip. This is the mouth opening. You have upper lip and lower lip. Which lip should we use to close the mouth? The lower or the upper? Most of your patients will close their mouth using the lower lip. So they will give you boxer profile. You will not like that chin. Try to train them to relax the lower lip and to activate the upper lip. The muscle of the face, they are voluntary muscle. We have two types of muscles, involuntary and voluntary, okay? So the muscles of the face, they are voluntary, which means you can control them. So you can train your face muscles like if you go to the gym. If you go to the gym, you can train your muscles of the body. Why not to train the muscles of the face? And you'll see with me, some cases, how much we change the face just by training the muscles of the face. So upper lip, using upper lip, I mean lip seal exercise using upper lip. I had Layla, okay, she has bimeridial protrusion. I could align her teeth without extraction. But if you use conventional brackets and you put your initial wire, what will happen for the proclination? It will increase. So patient will refuse continuing the treatment with you, and they will go for your colleague. And they will consider that you failed treating their child because of this Bimax. So we extract in orthodontics because we are afraid to get more proclination, and always parents, they will not like that. They hate if any accidental space, they hate the parents, I mean, any accidental space, and they will hate any proclination. That's why we extract in these cases, not because we are not able to correct the alignment, but always we will have proclination. But I decided not to do extraction in her case, and I finished her case. So one day when I was editing her case after finishing, I was doing that at home. So I have my wife and my daughters beside me, okay. So once I put her photo like this, they said, wow. Myself, I didn't see what they have seen. Even I couldn't know why they said wow. Because for me it's okay. But then I discovered, no. She has very beautiful smile. Even I'm using her smile as my reference in my lectures to show the normal smile. Then I decided to go back to her case to know why she had that beautiful result. So this is the day of bonding. This torque is wrong, by the way. Okay? Don't take photograph for that torque. It's wrong. But I want from you to remember this contact point. Okay? So this was the start, and this was the end. See this line? They said wow because of the Y connectors. Of course, she has a broad smile, wide smile, everything. And at that time, I was not sure about canine recontouring, but imagine that I did 1 millimeter of canine recontouring. What will happen for this canine? It will come down. So it will settle 100%, and I will have a wide connector here. So the only missing thing in her case is to have the canine a little bit more down with recontouring. Same on the left side. The only missing part, I need this canine to come down. So in other cases, I did the recontouring. That's why tomorrow in the hands-on, I'll bring red marker and I will mark the cusp tip of upper canines for your type of ont, so you remember to do that in your practice. So you see the amount of connector between hair teeth. The same for the lower arch. But at that time, I don't have the handpiece and the strips. So I did the IBR manually every time. So it was so difficult, yeah. Even the overjet was corrected without the class 2 elastics. All of that happened, why? Because I picked low torque, the uppers. So each time when I do IBR, I will get space, isn't? You do IBR, so you will end with a space. Once you put the wire, what will happen to that space? It will close. Okay, imagine that you have low torque brackets and you did IBR and the wire is 18 by 25. You finish the IBR. And of course, you are doing the IBR while the remover, the wire is outside the patient mouth. Okay? So once you put the wire back, what will happen for that space? It will close while the patient is still on the chair, isn't? Imagine that you are going to do that each visit. So with time, what will happen? This is what will happen. Retroclination with low torque, okay? So even the profile changed, even the patient mouth shape changed. So we restored the whole face just by gradual torque expression, gradual. And this movie, the sound is a little bit high, by the way. I will reduce the sound. Would you please follow the inclination of upper and lower incisors to see what happened with hair case? Be ready. Have you seen the retroclination? And big change in hair smile. So again, lip seal, nasal breathing, gradual IBR using low torque. By this, you can treat any mild Bimax. And remember something. It's normal and it's favorable to have some Bimax between the age of 12 till 16. So what you see as Bimax at this age will not be any longer Bimax after the age of 16, because after the age of 16, you will have some sort of facial maturation. Facial maturation means more chin, more nose. So if you judge your Bimax at the age of 12, 13, 14, and you see that it's obvious Bimax, just leaving the patient without a treatment, the Bimax, if the patient has lip seal, will reduce by time. So if you decide to extract now, you may later on not to extract. Okay, that's why never extract in Bimax. I will show you a severe case in which I'm trying to do my best to have relapse because we did too much retraction without extraction. Okay, so if you see a case at young generation, 12, 13, 14 with Bimax, it will not be a Bimax at the age of 20 because all of our patients will have maturation of this part of the face and this part of the face. More chin, more nose. Okay? You need this support. She's not the case, but to show you. We started at the age of 12. I think we finished at the age of 13. Do you see the amount of proclination I did? So if you evaluate the lateral SAF alone, is this good or bad? Don't be shy. Tell me. This is bad, isn't it? This Pimax is too much. If you see an X-ray like this, oh, your doctor didn't treat you well, okay? But this was at the age of 13. Same patient. Okay, I finished her case like this. Her face at the start of the treatment, at the Panorebo at the end of the treatment, okay? Full lips, too much lips, okay? Even the gummy smile, the same. Don't judge gummy smile at this age, okay? Don't do gum surgery or intrusion, okay? This is normal for this young generation. At Panorebo, after debonding, see the amount of gummy smile? This is bad. But again, this is normal at that age, which is 12, 13, 14, 15, okay? Don't do gum surgery, don't do intrusion or extraction, depending on the Pimax or the vertical instant or transient gummy smile, okay? I'll show you that case after 3 years, okay? This is here after 3 years. Okay. I used her as one of my models, okay? So what you have seen as Pimax or gummy smile will change with age. And age is with you for gummy smile and Pimax. It will not be against you. Keeping in mind that she has lip seal, nasal breathing, and she don't have tongue thrust habit. Yeah. Sometimes you will not see that tongue thrust in the practice. Some patients, instead of clenching at sleep, they are doing tongue push at sleep. So tongue thrust is not only swallowing habit, sometimes it's clenching habit. Some patients, they will not show you the tongue thrust while you are treating them. They will make that tongue thrust as stress relieving while they are pushing the upper and lower incisors. And you can make tongue tamers part of retention, okay? But never extract, never do gum surgery. Would you please wait without taking any photos? So in mild bimaxillary intrusion, we are depending on low torque and gradual torque expression after applying IBR and establishing something called good habits. Good habits means nasal breathing, lip seal, and to search if there is any tongue thrust habit, okay? Got it? And it's normal to have some proclination and accepted gummy smile in young generation. Done? Done, okay. For the severe one, when I say severe Pimax, I mean class 2 in the upper and class 2 in the lower. So if we are talking about class 2 in the upper and class 2 in the lower, class 3 in the lower, what you are going to do with wisdom teeth? Extract upper and lower, okay? In a class 2, what torque that we are using in the upper? Class 2, what torque that we are using in the upper? Torque, in the upper. Class 2, upper. High torque, thank you so much. What torque that we are using in the lower, in the class 3 cases? High torque. So what torque that we should use here? High torque. So just bring a class 2 mechanics with a class 2, 3 mechanics and put them together, okay? So it's better to use high torque. And for the canines, remember when I told you, this is my upper canine, okay? If I push my roots of upper canines toward the cortical plate, the canine will not move. So I should put high torque, so I will keep the roots of upper canine away from the cortical plate, so I can do distalization. The same for the lower canine. I should use high torque to keep my roots away from the cortical plate to have also distalization, okay? So for upper and lower canines, we'll use high torque. As usual, eliminate any rotation, correct any crossbite, finish your panorebo. We are not going to do IBR now, okay? We are not correcting the severe one with IBR because we are using high torque. So what we are going to do, after 16 by 25 Celestine, we'll add TAD between upper 6 and 7. This will give you class 2 mechanics in the upper arch in order to create space mesial to upper canines. This is for the upper arch. Then we need for the lower arch to use the class 3 elastics. Normal class 3 or Balathel? We don't have constructed maxilla, so we'll use normal class 3. So we'll use the class 3 elastics from upper 6s to lower canines to create space mesial to lower canines. So by this, you will create space mesial to upper and lower canines. Then you can do symmetrical retraction of upper and lower anterior segment or asymmetrical, depending on if there is midline shifting. Again, good habits, nasal breathing, lip seal exercise using upper lip. Remember when I told you, treat any patient as your colleague? She came to me as a school child. Now she is my colleague. Okay. So she has Bimax. And what's more, she is 20 years old and locked 7s. I'm not sure why, but always when I show this case, all doctors, they will think with this. We'll put mini screw here and mini screw here to upright the second molars. They will think how to complicate the case. No, it's easy. So the first thing, as we have said, what you are going to do with wisdom teeth? Extraction. Extract them and give the chance to upper and lower second molars to have some sort of self-correction. And in most of the cases, they will be self-corrected without having any complicated procedure. She was studying at the dental school in Jordan, and she had consultation from her teachers in the orthodontic department. All of them, they were for. Give her the same advice. You have Bimax, and you have lock 7s, and lock Lydia, you have incompetent lips, and if we treat you without extraction, this will increase. So the only solution is to extract upper and lower 4s. Okay. She came to me, I told her I will not extract. I will extract only the wisdom teeth. So each time when she had the braces in the college, they will tell her, I mean the teachers, look, Lydia, still you are treated by Badr, isn't? She will say yes. Look, Badr will send you back to us to extract upper and lower 4s at the end. This treatment will be a failure. So each time when she comes to me, I need to do two things. I need to do my mental treatment, I mean to give her positive energy, and I need to challenge myself and to make things perfect, okay? That's why I did overcorrection in her case. So I told you it's better to use high torque. In her case, she was one of the initial cases to me with this protocol, like the Big Brother rules. All what you have seen with me is my recipe, okay? So I was afraid to lose the success in her case, so I picked low torque upper and low torque lower. But because I picked low torque, we did overcorrection, and she added filler for the upper lip. You imagine, okay? So once we extracted the eighths, we had some sort of eruption of second molars, because I was afraid that I will not be successful in her treatment. I picked low torque with a standard torque in the centrals, or maybe no, it is low torque. But later on, before finishing, I changed this to standard torque. So this is the day of bonding. I added my bite razors on the lower molars. By the way, don't bother yourself for the frontal views. Why not to go to the buccal? It's more important. So as I have told you, I changed the torque to standard torque in the centrals. But if I'm going to treat here again, I'll put everything high torque except upper laterals. They should be, if I'm going to treat here again, I'm going to put everything high torque except upper laterals. They will be standard torque. So this is a bonding session. The extraction for upper wisdom teeth was so fresh. These are the sutures. I will not bother myself with this scissor bite. Okay. Still, you have time. Okay. Just by waiting, I don't have now scissor bite. Okay. So I bonded the 7s. And I put my min screw between 6 and 7. It was Victor Taz 8 millimeter. For me, Victor Taz, the best TAD in the market. Why? Why Victor Taz is the best Victor Taz in the market? Have you heard with a doctor, his name is Johnny Graham? Johnny Graham, he was a maxillofacial surgeon in the States. When you say MaxFax in the States, we are talking about at least $1 million per year. Okay? Should I repeat? When I say maxillofacial surgeon, Johnny Graham, in the States, okay, his income will be not less than $1 million per year. So every day, he used to go to the theater to do what? Surgeries. Surgeries in the face. And most of his surgeries will be Le Fort 1. If you have any patient with Le Fort 1 surgery, try to hold the mirror and try to knock on the maxilla. You will hear horrible sound. Dull sound. You will not have that resonance, okay? And if you try to hold the maxilla, even if you have the best surgeon ever, the maxilla will move. So there is no union in the fourth one, real bony union. Always there is fibrous one. And of course, in some cases you will have bleeding, in some cases you will have failure, in some cases you will have necrosis. So what he did, he quit, like my wife, okay? He quit MaxFax, and he went back to school to study orthodontics. And he invented these screws. That's why these are the best screws, because they were invented by a MaxFax to avoid Le Fort 1. Okay, so this is the story behind them. And I have a story behind white connectors, by the way, okay? And tomorrow we'll share that with you. they have 4 sizes, 6, 8, 10, 12. You need to buy only 6 and 8, and they are pure titanium, and they are made from the same material like implants, okay? And I'm not sure if you have anything of them in your company. I mean the screwdriver, if you have the screwdriver, if we can have it tomorrow, just to make other colleagues, just to hold the screwdriver. You will feel that you are holding a gun. It's so heavy, and you feel yourself in control, okay? So I put 8 millimeters min screw between 6 and 5 without angulation, straight, okay? Because the amount of bone between 6 and 7 is good. If you go apical and at the junction of attaching mucosa and aligning mucosa, the amount of bone is enough. So this is my class 2 mechanics. I want to retract the buccal segment with some intrusion to counteract the class 3 elastics in order not to rotate the occlusal plane, okay? So class 3 elastics, class 2 mechanics. And creating space mesial to upper and lower canines. Then once I have that space, I have my upper anterior teeth as one segment, my lower anterior teeth as one segment. I'm retracting both segments. And I finished his hair case like this. I did overcorrection, see? And I used to leave this expensive titanium min screw as souvenir. I will not remove it, okay? I used to leave it for 6 to 12 months, of course, for retention. We'll need it. This is what happened for the upper arch. By the way, this amount of space, mesial to upper canine, is the same amount if you extract upper 4s and you did retraction for upper canine. For those who extract, you extract the premolars, then you retract the canine at the site of the premolars as stage 1. The remaining space mesial to upper and lower canines will not exceed 2 to 3 millimeters. So if you can create that 2 millimeters or 3 millimeters without extraction, why to extract? I have enough space to do retraction. I did my retraction. Remember the locked 7s? I didn't bond them at the first stage. I bonded them later on, so I uprighted them. And these are my min screws. And this is the space that I created. And this is the final result. I uprighted the second molars. I lift my min screws. I have enough bone. Everything is great. What about the lateral shaft? We started like this. We finished like this. And this movie is so important. I need from you to follow lower 7s and upper 7s, keeping in mind that we extracted the 8s. And to see that what we have done is total distalization for both arches. So we had 8s here, okay? So remember today when I told about the science behind the immune system is the space distal to upper and lower 7s. It will help you to treat any case, class 2, class 3, by max, even open bite cases. When I told you about tongue thrust habit, so whenever there is bimaxillary protrusion, always expect anterior tongue thrust. So add tongue tamers in the retention protocol. So keep the tongue tamers in your retention protocol if you feel that you have tongue thrust. Hair profile before and after overcorrection. If you follow the movie, Overcorrection. That's why she added some fillers for the upper lip. Imagine, now she has big nose and almost normal chin. And she couldn't bring lip to lip, okay? But with the training, lip seal exercise, things are going better. From here to here. Too much, she is now 24 years old almost. So this is too much. So I wish if she will have some relapse, by the way. Her smile from the beginning to the end. Big change in the face. In this movie, you'll see the change in her smile. So the whole thing was retracted, okay? I need 5 minutes to 10 minutes to finish with TADS, okay? So tomorrow we'll be ready for open bite cases. I told you the story behind TADS, Victor TADS. They come in 4 dimensions, 6, 8, 10, 12. Don't buy these. No need. Only buy 6 and 8 millimeters. The good thing with Victor TADS, they will give you a map where to put your Victor TADS. They come in a sterile package. This is the 6 millimeter mil screw. And this is the screwdriver. In this case, I'm using 4 mil screws to impact the maxilla. Use to give only infiltration. I'm penetrating the cortical plate. After that, you need only to apply very minimal force. Just rotation.
Perfect.
This is the case. By the way, she is my relative. Before traveling back to Qatar, these are the screwdrivers. I used to keep the failed mil screws for hands-on on typodonts or in the jaw of sheep. Okay. Yeah. I'll talk about Sabil for a few seconds. She came to me with a skeletal class 1, deep bite, and poor prognosis, lower right 6. Okay? So sometimes the age is the decision maker. Her age is what? 19 years old. Okay? You have shortcut and you have long way. The shortcut is what? Sabil, you need to extract upper and lower 8s. And after finishing the treatment, you need to do implant at the site of the first molar. You can finish her case with 1 year, but she will end with implant. But I told her, look, Sabil, I can go for extraction of this tooth, and I will protract the second molar and the 8, but I may need more than 2 years. Do you go back to me and tell me, doctor, you spent more than 2 years on my case. It's my right to finish your case within 1 year, but I want to finish with natural occlusion, okay? She accepted, and we extracted that tooth. And always when you have extraction, what should I have on the lower arch as torque? High torque. Always when you have extraction, it's better to have high torque. So I put high torque on the lowers. By the way, this is, these are right, but these should be standard torque. Later on, in the Panorebo, I changed them to the right torque. I put my min screw between 4 and 5, 8 millimeter to protract the 7. This is her Panorebo. I was not happy about the incisal show. and this lateral was not right. By the way, this is the 7. We protracted that, and we are waiting the 8 to erupt. We extracted upper right, upper left, lower left 8s. These are the new torque, and I put them more gingival to show more of hair incisors. And I finished hair case. By the way, this gum show is not real. You need to wait. This is my mini screw. I'm pushing or I'm pulling the second molar. We had the 8 at the side of the 7. We have the 7 at the side of the first molar. This is my new bracket positioning. I put them a little bit more gingival. I put my bite razor on canines because it's nonsense to put them on lower first molars because I have extracted one. Sometimes, even with any system, it will be impossible to correct that tooth. Why? Already congenitally, the shape of the crown is abnormal. So you will not be in 100% control. But we could align that lateral. I used the tube of 6 on the 7. We are protracting that tooth till we have the 8. So we finished with this nice alignment. So this is the start and this is the end of the treatment. By the way, this is not real gum show. This was the start. We extracted 8, 8, 8, and this 6. See the malalignment of the lateral, even it has this shape. So always take care of the shape of upper laterals. Always upper laterals, they have variation, anatomical variation. I put my mini screw between 4 and 5. The 7, I tilted the tube of the 7, so I will have my roots in more mesial position to have overcorrection. That's why at the end of the treatment, you will not be able to differentiate between right and left side. We were lucky because she has single root, second molar. Still, the lateral has abnormal shape. For the profile, we improved the lip support because we used high torque. She has well-developed nose and chin. We need this. Yeah, more lip support. And for the smile, I feel that she has reduced smile incisal show. That's why I put my brackets more incisal, even though I felt still the incisal show is not. I put my brackets almost at 7, but this will give you a clue about the power of high torque. So the high torque will bring your incisors like this. So even if you use the class 2 elastics, it will control the position of upper incisors. So she needs some sort of cleaning and whitening. I think, yeah, we finished the whole program today. Dr. Fong, thank you so much, okay? You did an amazing job and we should thank you, okay?